Van Mieghem from the Thoraxcenter. I think I have to restart. Good morning, everyone. We are very happy today to have Dr. Nicolas Van Mieghem from the Thoraxcenter in Rotterdam to join us. So it's an hybrid event. We have people in the room and people online. For those in the room who want to ask questions at the end of the presentation, please go to the mic. And the others, you can use the chat box. And if you're experiencing any difficulties, you go to the chat feature. So Dr. Nicolas Van Mieghem is an international star in interventional cardiology. He is the clinical director of interventional cardiology and professor of interventional cardiology at the Rotterdam Thoraxcenter. He had his medical degree at the University Catholic of Leuven in Belgium. He is fully, I think, language, so French, Flemish, English, German, so forth. He did a fellowship, I need my note, at the Ziekenhuis Oost Limburg, Ghent, Belgium, Lenox Hill in New York, and the Thoraxcenter in Rotterdam, of course. He joined Rotterdam as a staff in 2010. His main interest is complex coronary lesion, mechanical circulatory support, and structural heart intervention. He's a fellow of the European Society of Cardiology and fellow of the American College of Cardiology. I was impressed when I checked in PubMed, more than 600 publications so far in PubMed in peer-reviewed journals. He's a PI and participating in the steering committee of numerous randomized controlled trials in coronary and transcatheter valve intervention, including the TAVI and LOT that we will discuss today. On a personal note, I look at your CV. You are an accomplished swimmer. I didn't know that. At the national level. He's just back from TCT, and it was not easy to have him here because a lot of issue with flight booking, but we are very pleased and honored to have him today to discuss TAVI for moderate AS. Let me welcome Dr. Van Mieghem. Thank you very much for being here.
So thank you very much, David. It's a true pleasure and honor to be here in Ottawa. It's my first time in this part of the world. I've been to Vancouver before, but never to the province of Ontario. So what I'm going to do is I'm going to spend the next 30 to 45 minutes talking about moderate aortic stenosis. And let's just build up with some history. We are all familiar with these graphs where we know that as aortic stenosis is developing, it takes time and it remains asymptomatic for quite some time. But once, oops, this is going too fast. But once symptoms kick in, also the prognosis of the patients is severely impaired, and we are familiar with the typical symptoms of chest pain, dyspnea, syncopes. And we are also familiar with aortic stenosis progression, and also David did a lot of research in that field. And what can you expect in principle that on an annual, if you look at the annual pace of disease progression, you see an increase of maximum velocities of approximately 0.3 meters per second, and the valve areas will decrease with approximately 0.1 centimeters square per year. But there are also indication or situations where there is an accelerated progression. And this is obviously when the aortic stenosis becomes more severe, also the progression accelerates. If there is more calcium, there is also faster progression. It seems to progress faster in men than in women, and also more in Caucasians than in other races. Now let's talk about moderate aortic stenosis and the diagnostic tools. Obviously, everything begins with echocardiography. Echocardiography is the mainstay of the diagnosis of valvular heart disease, also for aortic valve stenosis. But we have to bear in mind that when we are doing an echocardiogram, we are making some assumptions, because we approach the aortic valve as a circular entity, which it isn't. And that's where also the issues start with the interpretation or potential interpretation of echocardiography for aortic valve stenosis. And there are also some technical issues, right? If you're not able to to align the beam with the flow, you will underestimate aortic stenosis. Luckily, there are also other tools, for instance, CT scanning, especially in the planning of our procedures, but also for diagnostic purposes. For instance, the amount of calcium is also helpful to determine a diagnosis of severe aortic stenosis. But in the in-between cases, the borderline cases, we are relying on dobutamine stress echo. So if you have this discordance, for instance, you measure a valve area that is in keeping with severe aortic stenosis, but your gradients are not concordant, then a dobutamine stress echo can help you. So in low flow, low gradient situations, the dobutamine stress echocardiogram may help you to make the diagnosis of severe or moderate aortic stenosis, because as we are thinking, as we were designing the trial TAVR Unload that was focusing on patients with moderate aortic stenosis, we already realized that, okay, the patients with pseudo-severe aortic stenosis, so who underwent a dobutamine stress echo, and it turns out that the valve was not severely stenosed, that is a patient that would be a good candidate for the TAVR Unload study. But also on the other end of the spectrum, you could imagine to face a situation with pseudo-moderate aortic stenosis. So also on that side of the spectrum, you can do a dobutamine stress echo to ensure that the stenosis is moderate and not mild. So on both ends of the severity spectrum, we were relying on dobutamine stress echo to determine our diagnosis. But some of you may have now the inclination, well, if we also have CT and we have the calcium scoring by CT, maybe that would allow us no longer to rely on dobutamine stress echo, because the CT interpretation is much easier. Also logistically, it might be much easier to do. Well, that is not the case. So we did a study recently in the Thoraxcenter where we had 214 patients with a discordant aortic stenosis. So valve areas were below 1 centimeter squared. The gradients were below 40 millimeters of mercury. And all those patients received a dobutamine stress echo. And our question was, okay, can we predict the result of the dobutamine stress echo with our CT scanning? And is there a concordance between the calcium scoring, the Agatston score, the severity by Agatston score, and the result of the dobutamine stress echo? Turns out that there was a poor correlation between the Agatston scoring and the outcome of the dobutamine stress echo. So we had a series of patients where the Agatston score was relatively low, but the dobutamine stress echo was in keeping with severe aortic stenosis. And you may be familiar with non-calcific and more fibrotic leaflets that also can create aortic stenosis. So you would miss that, you might miss that with your everyday echo, and you will have a low Agatston score by CT scanning. So you always have to be very careful. But there's also the other side. You can have severely calcific aortic valve leaflets, but relatively low gradients. So there is no one-to-one correlation between the Agatston score and the results of a dobutamine stress echo. And what was interesting from our study was that all the patients who underwent a dobutamine stress echo, they all received a valve replacement within 5 years, and most of them within the first year. So also the patients where we ended up with a diagnosis of pseudo-severe, therefore moderate aortic stenosis, they progressed relatively rapidly to severe status and then underwent aortic valve replacement. So I think this already tells you that, well, should we keep using these categorical thresholds for severity, or should we treat aortic stenosis as a continuum rather than black or white? It is severe and you need to treat it, or it is becoming severe and it's already of interest to consider treatment. So what are the issues with moderate aortic stenosis? Well, first of all, this is a large echocardiography registry from Australia, where it became clear that over a 5-year follow-up window, the outcomes with moderate aortic stenosis are approaching severe aortic stenosis. So the survival rate with mild and no aortic stenosis, more or less the same, but you see a steep increase in mortality with patients with moderate aortic stenosis. And basically, this was also echoed in the United States, where Philippe Généreux had access to an enormous database of more than 1 million patients, where it turns out that if you look at hospitalizations, but also at mortality, that patients with moderate aortic stenosis definitely are doing worse than patients with mild aortic stenosis. And if you look at mortality at 5 years, that moderate and moderate to severe aortic stenosis approaches the outcome, the dismal outcome of patients with severe aortic stenosis. So moderate aortic stenosis is not an innocent bystander. This is from a meta-analysis, including 25 studies, where it's clear that the event rate is quite significant, the annual event rate for patients with moderate aortic stenosis. Is it different from, in that same meta-analysis, it was also clear that moderate aortic stenosis is not the same as severe aortic stenosis. So severe aortic stenosis still has a hazard ratio of 2.2 relative to moderate aortic stenosis, and moderate aortic stenosis is associated with a higher mortality than no or mild aortic stenosis. So what is then the interaction of heart failure and reduced ejection fraction with moderate aortic stenosis? And as you can tell, I'm building up to the randomized controlled trial that is the TAVR unload that we will discuss in the second half of my presentation. So the impact of ejection fraction was also clear from that meta-analysis, because here you see that patients with moderate aortic stenosis and an ejection fraction less than 50% had a significantly higher mortality rate, event rate, than the patients with an ejection fraction of more than 50%. And this was also duplicated by Jeroen Baks in Leiden, where he looked at a large database of patients, almost 2,000 patients with moderate aortic stenosis. And it turns out that when the ejection fraction drops below 50%, that is when the event rate starts to increase. And there is this inflection point below 60%. That is when you start to see a significant increase in outcomes. What were the major predictors for all-cause death? It was obviously when patients were more symptomatic or when the ejection fraction was less than 50%. I think we were the first in 2017 to highlight the issues of moderate aortic stenosis in patients with heart failure. And we pooled data from 4 academic sites, including also our friends in Quebec, where it became clear that patients with ejection fractions below 50% and moderate aortic stenosis, well, they have an annual event rate that is quite significant in terms of survival, but also in terms of hospitalization. So a lot of those patients were having events. So that became the basis of the TAVR unload. And this is another study by Jean, also from Canada, where they looked at heart failure patients with and without moderate aortic stenosis. And just the presence of moderate aortic stenosis steeply increased the event rate of those patients. A recent large literature review is the last piece of information that I wanted to share in terms of the outcome of moderate aortic stenosis, where you can see almost 400,000 patients with no or mild aortic stenosis were compared to 11,000 patients with moderate aortic stenosis. And as expected, patients with moderate aortic stenosis are somewhat older, and as expected, their gradients are higher, their valve areas are lower. But now look at the outcome of those patients. So if you do the raw comparison, so in a non-matched population, then it seems to be that moderate aortic stenosis is associated with worse survival. But if you then do a matched comparison of the patients with moderate aortic stenosis and no or mild aortic stenosis, all of a sudden, there is no longer a difference in outcome between those patient populations. But the different situation when the ejection fraction is dropping below 50%. So in the raw comparison, again, moderate aortic stenosis, not a good thing. But also when we did when they did advanced matching, you could notice that there was still a significant difference with worse outcomes in patients with moderate aortic stenosis. So the combination of an ejection fraction of less than 50% and moderate aortic stenosis seems to be a bad thing. And also of interest is that the event rates are very high early on. So once you make the diagnosis of moderate aortic stenosis, well, the event rate seems to be quite high in the case of in the case of LV dysfunction. So then you ask yourself, okay, but is there a space for upstream management? And what is upstream management of aortic stenosis? Well, we are all familiar with the concept, and that is what the guidelines recommend. As the valve is deteriorating from normal to mild to moderate and then to severe aortic stenosis, you only consider treatment when the patient becomes symptomatic. So you have to wait for severe aortic stenosis to become symptomatic to have like a full, strong recommendation for aortic valve replacement. But a lot is happening in between. So the question is, should we not consider treating aortic stenosis earlier? And this is preemptive upstream management of aortic stenosis. The two indications are symptomatic moderate aortic stenosis and asymptomatic severe aortic stenosis. Because what is happening as the valve is progressing or deteriorating from normal to a severe aortic stenosis, things are changing in the myocardium. And there is a remodeling, but there is also maladaptive remodeling. Fibrosis is kicking in. And at one point you have replacement fibrosis, and that has been associated with sudden death, with heart failure hospitalizations. As a matter of fact, it is also associated with irreversible remodeling. So maladaptive remodeling means that you can replace the valve, but the harm has been done and the patients remain at risk, for instance, for sudden cardiac death. So if we would treat the patient earlier on, would we then make a fundamental difference in survival of those patients? Well, we know that aortic stenosis by itself is a pressure overload to the valve, to the heart. And if it stays long enough, it transitions from a pressure overload to a volume overload. Once it is a volume overload issue, then I think we should conclude that we are too advanced and the patients will not do well even if they have their valve replaced. So the question is moderate aortic stenosis then a valid target for valve replacement? Well, there are some indirect arguments in favor, and this is just a theoretical issue. If you look at the ventricular arterial impedance, then, and this is work from Philippe Barrault, if it's high, then it means that there is a lot of loading to the ventricle. And though when it's high, that also affects outcomes. So the outcome is worse, survival is worse, and mortality is highest when there is a high ventricular arterial impedance. But ventricular arterial impedance is not only determined by the aortic valve itself, it can also be determined by the arterial system. But that doesn't matter. If it's high, it is associated with a worse prognosis, regardless whether it is fully determined by the aortic valve or whether there are other issues. But the point is that it is a combination of the two, right? So there is the burden by the valve and there is the burden of the arterial system. But at one point, yeah, this arterial component can no longer be addressed by medications. So the arterial system becomes, as people get older and the arterial system gets stiffer, we will be less and less able to reduce this arterial component of the loading. And then the only remaining target is the valvular loading of the ventricle. So that is an argument to consider treating moderate aortic stenosis in patients with a high valvular arterial impedance. So TAVI should then reduce also the loading, overall loading of the ventricle. Now, there is a retrospective analysis where we also participated in, where we compared patients who received TAVR for moderate aortic stenosis in everyday practice with patients coming from the Atlas TAVI registry. And turns out that the patients in a matched comparison who had their valves replaced had best outcomes. So, and these were patients with pseudo-severe aortic stenosis. Well, they did better when they were treated with a valve replacement. And same thing that we saw in our own data set in Erasmus, where we compared the patients who participated in the TAVR Unload trial with a set of patients with moderate aortic stenosis, depressed LV functions, who were treated conservatively, who underwent clinical surveillance. Well, it turns out that the patients who received a TAVR did best overall at the long term. So that brings us then to the TAVR Unload. And the TAVR Unload is the first randomized controlled trial evaluating TAVI in the context of moderate aortic stenosis, but specifically in patients with depressed LV function. And we ended up with 178 patients that were one-to-one randomized to transfemoral TAVR with a balloon expandable valve, with a sapien valve, or clinical surveillance. And the patients in the clinical surveillance were only allowed to undergo TAVI or TAVR when the moderate aortic stenosis had progressed to severe aortic stenosis. By default, all these patients were symptomatic. They had heart failure, so they were at least in New York Heart Class 2. And our primary endpoint was a hierarchical occurrence of all-cause death, stroke, heart failure hospitalizations, or events that were equivalent to a heart failure hospitalization, and then fourth, a change in quality of life. Now, when I originally designed the trial, that was in 2012, we were trying to do a risk estimation, and we decided that we needed 600 patients with the primary endpoint analysis at 1 year. It turned out to be a difficult trial to enroll. Why? Well, we as cardiologists, or the cardiology community, is not trained to be triggered by moderate aortic stenosis. In principle, when you have the diagnosis of moderate aortic stenosis, you tell the patient, well, you come back in a year and we'll check your echo again, and that's it. So it was very difficult to get the referrals from our referring hospitals for the context of moderate aortic stenosis. So that slowed down the process. It took some time to educate our referral basis to start referring those patients. And then, unfortunately, in 2022, we were forced to stop the trial because of slow enrollment, but also because the Progress trial started enrolling patients. And Progress was a big industry-sponsored trial looking for IDE approval for the indication of moderate aortic stenosis. Now, going back to our trial, the patients that we included were at a mean age of 77 years old. 1 in 5 were women, and their STS score was more than 4. So in keeping with the risk profile of patients with an intermediate risk. They had advanced heart failure, and advanced heart failure, why? Well, more than 50% were in New York Heart Class 3 or ambulatory Class 4. Approximately 50% had a heart failure hospitalization in the year prior to study enrollment, and their KCCQ overall score was 56, so less than 60. So that is in keeping with New York Heart Class 3 or more. And their ejection fraction, the mean ejection fraction in the trial was 39%, with LV and diastolic diameters of more than 6.5 centimeters, so dilated ventricles. Patients had moderate aortic stenosis, and the moderate aortic stenosis had to be confirmed by an independent core lab. Mean valve area was 1.2 centimeters square, and the mean gradient was 22 millimeters of mercury. Now, the interesting part is, so patients were randomized to TAVR or clinical surveillance. So it is important when you would consider preemptive TAVR treatment, that your treatment itself is a safe procedure. So there should not be a penalty or a major penalty of the procedure per se. So it was very important to look at the 30-day outcomes, and these were also in keeping with what you could expect from a low-risk population. So in that, we were quite happy to see that the event rates were very low following following on the procedure. But what was happening in the patients who underwent clinical surveillance? Well, there was progression to severe aortic stenosis. And I started my talk by saying, well, you can expect that the valve area might decrease with 0.1 centimeter square per year, and the maximum velocities may increase with 0.3 meters per second per year. Well, that is definitely what we also saw in the trial. So 39% of the patients progressed from moderate to severe aortic stenosis within the first 2 years of the study. And most of those patients, well, 20% of the overall population, already had progression, disease progression from moderate to severe in the first year. And then every year, more and more patients were progressing from moderate to severe. And all those patients who progressed underwent a TAVI. And half of those had a heart failure event at the moment that they received the valve. So eventually, 43% of the overall control arm received TAVR. Now, if you look at the clinical event rates between the two treatment strategies using a MACE endpoint, so we are very comfortable interpreting MACE, and also all-cause death, a heart clinical endpoint, we did not see a difference, a significant difference between the two treatment strategies. The primary endpoint was this hierarchical endpoint that I mentioned, using the Finkelstein-Schoenfeld method. And what does that mean? We have 4 components: death, stroke, hospitalizations, and quality of life. And you will compare every single patient in the treatment arm with every single patient in the control arm. So patient 1 is compared to patient 1 in the control arm, but also with patient 2, 3, 4, 5, and so on and so on. And so you start comparing. And first, you're going to look at mortality. So if you compare patient 1 with patient 1 in the control arm, you look at, did one patient die, yes or no? If one died, then that was a win for the patient who survived. If there was no death, then you move on to the second component of the hierarchical endpoint, which is stroke. And then you do the same comparison. Did the patient get a stroke, yes or no? If yes, then that patient lost. If no, then you go to the next level, which is heart failure hospitalization, and so on. So gradually you see that, there was no difference in mortality. There was no difference in stroke. You saw numerically more wins in terms of hospitalization in favor of the TAVR arm, and also numerically more wins in terms of quality of life improvement. But at the end of the study, at the longest follow-up, there was no significant difference in this hierarchical endpoint between TAVR or clinical surveillance. Now, that was at longest follow-up. If we would have stuck to our original endpoint at 1 year, then we would have ended with a positive trial. So at 1 year, there was a statistical significant improvement in this win ratio. So we had more, the win ratio was statistically in favor of the TAVR arm. So we need a little bit of granularity there. If we only look at the patients in the clinical surveillance arm, and we are looking what is happening with those patients, and we look at the number of patients that are receiving a TAVR over time during the trial in the clinical surveillance arm, and most of them, again, because of progressive aortic stenosis. And we look at the patients who are dying without receiving a TAVR. Well, then it turns out that at 3 years, there were no patients in the control arm who were alive without a valve replacement. So that was an interesting observation. Now, let's dive into the quality of life assessment. I told you at longest follow-up, there was no difference in the hierarchical primary endpoint. We also saw no difference in quality of life at longest follow-up between the two treatment strategies. Well, why is that? Well, I think the patient-centered, the crossover-censored analysis tells you the story there. Because when a patient with moderate aortic stenosis and depressed LV function receives a TAVR for moderate aortic stenosis, you immediately see a steep improvement in the quality of life. This is not happening in the control arm, but you see a gradual increase over time in the quality of life. Why? Well, because their moderate aortic stenosis has progressed to severe and they received a TAVR. Now, if we would censor the patients who progressed, so in whom the moderate aortic stenosis remained moderate, because it's not by default that every moderate aortic stenosis will progress to severe. Well, if we would look only at those patients, then their quality of life remained the same. And then you start to see that there is a major difference between the treatment arm and the control arm. So basically, in patients with moderate aortic stenosis, you immediately improve the quality of life after the valve has been replaced. And if a patient with moderate aortic stenosis and heart failure is on guideline-directed medical therapy with no further ability to escalate with medical therapy, then the only way of improving the quality of life was to reduce the afterload further by replacing the valve. So what was the progression? What were the predictors for the progression to severe aortic stenosis? Well, as expected, the higher the gradient when patients entered the trial, the higher the likelihood that they would progress from moderate to severe aortic stenosis. Also, younger patients progressed faster than older patients. And when the ejection fraction also was lower, no, that is not wrong. Just age and the gradients. Those were the most important. Now, today or yesterday at the TCT, one of the fellows also presented a more in-depth analysis of this conversion-censored analysis in terms of the primary endpoint. And also there, it became clear that if you censor the patients who progress from moderate to severe aortic stenosis, well, even at longest follow-up, but definitely at 1 year follow-up, there is a strong benefit in favor of replacing the valve rather than doing clinical surveillance. Now let's interpret the change in quality of life in TAVR unload. So when we start at baseline, you see that the baseline quality of life of these patients is more or less in keeping with the baseline quality of life of patients at intermediate operative risk pivotal trials. And remember, the STS score was around 4.4%, so that is also in keeping with the intermediate risk trials. And if you look at the improvement in quality of life, the improvements in quality of life in the low risk and intermediate risk trials was much higher than the improvement that we could achieve in the TAVR unload. But it was also, and so the improvements that we had, so the final quality of life mimicked the quality of life in the high-risk patient populations, the pivotal trials, but also in the mimicked what happened in the COAPT trial. So COAPT trial is also a trial focusing on patients with heart failure and reduced ejection fraction, obviously with secondary MR, with severe secondary MR. So we are maybe comparing apples and oranges, but what I wanted to say is that there is a limit to the improvements in quality of life that you can anticipate. Patients with heart failure, you will not bring their quality of life into the 90s because they have this underlying disease that you're not treating with the valve replacement. And this is also in perspective. So you see that in TAVR unload, we had an increase more than 10, but not up to 20 that you would see in the trials that evaluated patients with severe aortic stenosis. So TAVR unload and COAPT are heart failure trials. I would not consider them to be valve trials because we are focusing on patients with advanced heart failure, and those patients may have limited expected gains in quality of life. Now, also, we were looking at phenotypes that may or may not respond better to a TAVR procedure. So we looked at patients with an ischemic cardiomyopathy versus a non-ischemic cardiomyopathy. Well, the effects on ejection fraction and quality of life were similar regardless of the etiology of the cardiomyopathy. Granted, we have to acknowledge that most patients in TAVR unload had an ischemic cardiomyopathy. So 75% of the patients had an ischemic cardiomyopathy. But regardless whether it was ischemic or non-ischemic, the effects on survival and heart failure hospitalizations were similar. There's also this concept of cardiac damage. Cardiac damage means, well, it can be classified as follows. So either it's left-sided or it also includes the right side of the ventricle. If also the right ventricle is involved, obviously there is more damage to the heart, and that might also affect the outcome of those patients. Well, that turns out to be the case. If also the right heart is involved in the cardiac damage algorithm, and that means that the patient also has at least more than mild tricuspid regurgitation and or RV dysfunction, well, those patients will do worse. And that also was the case in the TAVR unload. But what happens then with these damaged ventricles? Are we able to revert the damage to the heart? Well, that is unpredictable. So you see both in the TAVR arm and in the clinical surveillance arm, obviously the clinical surveillance arm also eventually the patients who survived received a valve replacement, but it's very unpredictable what's going to happen. So a lot of the patients with cardiac damage, they remained with some kind of cardiac damage in the follow-up. And the effect of TAVR was the same whether or not there was advanced cardiac damage or not. So if the cardiac damage was restricted to the left heart or also included the right ventricle, that didn't matter. There was an effect of TAVR that more or less was the same. So are we the only randomized trial? No, we were the first randomized controlled trial evaluating patients with moderate aortic stenosis. There are two others, that is the Progress and the Expand TAVR 2. Those trials included this concept of cardiac damage for patient selection. Most patients in the Progress trial had a preserved ejection fraction. That trial completed its enrollment in 2023, and it will be presented next year. Then there's another trial, the TAVR Expand TAVR 2 randomized controlled study. That trial also completed its enrollment this year, and results are expected in 2027 to 2028. So in TAVR unload, there are limitations. I think, unfortunately, we were underpowered, and we had to prematurely end patient enrollments. I already explained to you why that was. That was this, we had to educate a referral basis. I think the most important argument, though, was Progress. And I can now say this. So TAVR unload was an investigator-initiated trial. The Progress trial was an industry-sponsored trial. But we had some funding from Edwards. Now, we built a complete infrastructure in all the sites that were participating in TAVR unload. But what happened was that most sites participating in TAVR unload were in the United States. Now, Edwards started Progress, and they approached all the sites that were participating in TAVR unload because they were already up and running, and they had, already educated their referral basis. And they said, well, now you have to stop enrolling in TAVR unload, and you have to start enrolling in Progress. So, that is the problem with the United States, and I don't have to tell you that, but also in Europe, we experience some frustrations, shall I say. And unfortunately, because I'm convinced that if we would have done the 600 patient enrollments, we would have ended with a massively positive trial. And so now we are sticking with this, unclarity, if you will. So to conclude, the categorical classification of aortic stenosis seems elusive. And I think aortic stenosis is a continuum, and you have to look at the gestalt of the valve, and a multi-parametric assessment seems essential. TAVR for moderate aortic stenosis in patients with depressed LV function on guideline-directed medical therapy is safe. We can say that, but it will not affect the hard clinical endpoints, but you will affect quality of life, and immediately after the valve is replaced, you will see a serious improvement in quality of life. And this effect resembles the effect in high-risk TAVR trials, but also an effect of TEER in patients with HFrEF and secondary MR seems in the same ballpark of improvements. And what do we have to do then for now when you are encountering or when you are treating a patient with heart failure and reduced ejection fraction and moderate aortic stenosis? Well, I think you need to intensify the follow-up. I think we should not send this patient out for another year, but bring the patient back at 3 to 6 months for a new echocardiogram, because there is a accelerated progression from moderate to severe, and then you already have a guideline indication. So you should not wait for that for another year. But if a patient remains symptomatic, despite guideline-directed medical therapy, I think it makes sense to replace the valve. Thank you for your attention.
Thank you so much, Nicolas. It was an amazing presentation, and thank you again for being here with us despite all the trouble. Any question from?
Great and insightful presentation, Professor. You know, a couple of questions I have. So we saw a change in, you know, patients' symptoms in a trial that they knew they're going in for intervention. I guess, how can we put this in the big context of, you know, this could be a placebo effect. You know, we're not seeing hard clinical outcomes. And, you know, if you tell them you're going to have a more intensive regimen of medications, you may see the same effect on the symptomatology post procedure. And then the other question is, we still have to decide on a threshold. So moderate aortic stenosis is a hodgepodge of patients. You have a wide variety of different types of patients, and also the you know, moderate aortic stenosis spans a big gradient, you know, from 20 to 40. Where would you, now that you see these trials, where would you put the cutoff still for a practicing physician to refer patients to you? Do you refer every moderate aortic stenosis, or do you in your mind now have a threshold where you want to hone down and decide on those patients, perhaps that they may get an earlier intervention?
Yeah. Well, to answer your first question, obviously it's difficult to come up with a double-blind trial and to have a sham control. So that there's always going to be a limitation there, and unfortunately, we have to acknowledge that it's going to be difficult to affect the hard clinical endpoints in that specific patient population on top of optimal guideline-directed medical therapy. So I think this is an important observation that we made. You will not affect the hard clinical endpoints. But I would not underestimate the effects on the quality of life. It is a softer endpoint, but the effects that you see on quality of life is completely identical with what we see in all the randomized studies that have been done with TAVR so far. So you see an immediate increase. If you compare TAVR to surgery, at 1 year, the quality of life in the two treatment arms will be the same. But at 3 months, you see that the quality of life with TAVR is significantly better, and both treatment arms have been treated. Now, this is, I think, what we need to realize is that when you do a TAVR for aortic stenosis, you will have an immediate increase in quality of life. I don't think that is disputed now. We have to acknowledge it is not a hard clinical endpoint. Then the second question.
To that, Nicolas, I'm sorry. What about a functional test, a VO2, something more objective?
Sorry, second?
A functional test, like a VO2.
So you mean exercise testing?
Yes.
I think, yes, that would be more, that would make a lot of sense to do. That would make a lot of sense to do. But I think from a logistical point of view, to put that into a randomized controlled study, there is quite some variability there.
Can I just push a little further? So in the background slides, you show there's a, you know, statistically significant difference between survival in the moderate aortic stenosis versus in the severe. So if we're seeing such a stark difference in hard clinical outcomes, why can't we expect a change in trials? I mean, again, this is a, you know, smaller trial, but should we not at least have the bar that if we're going to change practice, have a change in hard clinical outcomes? Because there is a difference. Because otherwise, when, you know, again, referring cardiology, and I'm a TAVI physician as well, I'm a surgeon, you know, so I think it's a great procedure. But for referring physicians to send us, they might say this is really in the end a palliative procedure if you're not changing hard clinical outcomes and just symptoms.
So I think in the retrospective registries, a lot of those patients have no symptoms, and that is essential in the story. I think we are not talking about treatment of asymptomatic moderate aortic stenosis, and that is where I believe also the crux is or will be in the interpretation of progress, because in the progress trial, symptoms were not a requirement to enter the trial. So that is going to be evaluated. So in progress, 750 patients with some kind of cardiac damage are randomized to TAVR or clinical surveillance, regardless of symptoms. So what I would recommend now is if a patient is symptomatic and has moderate aortic stenosis, that is the patient that needs to be referred to us if they are on optimal guideline-directed medical therapy. A lot of those patients maybe even by default, will have HFpEF, will have heart failure with preserved ejection fraction. So if they remain symptomatic, then I think it makes sense to evaluate those patients in a valve clinic and to already do a CT scanning to get a better interpretation or of the gestalt of that valve. And I think that we will move away from these categorical numbers like 4 meters per second or a mean gradient of 40 or a valve area of less than 1. I think we will be more integrating moving forward.
Thanks a lot for coming here today. It's great. I definitely enjoyed the talk. Can you tell me, like, what are the markers of the people who will not improve, though, or will in fact be worse after intervention? Like, have you looked at that, you know, rather than kind of, okay, we do all of these people to try to improve symptoms, like who are the people who are not going to respond? You know, do you have markers of like RV function, the gradients, like what are those markers?
Yeah. So that's a very good question. Not all the patients qualified for the TAVR Unload study. We had our inclusion and exclusion criteria. So if there is more than moderate valvular disease outside of the aortic valve, those patients were out. If the patient had advanced frailty, they were out. So there is also the futility concept that we have to bear in mind. So I don't think that this trial will allow us to identify a group of non-responders, if you will. In principle, we saw improvements in quality of life in all the patients in the treatment arm, in all of them. But that has to do with patient selection, obviously. Yeah.
And can you just make a comment? I guess the study started in 2012 and medical therapy was kind of definitely different then versus now. Like, how do you think that may kind of impact the results?
So let me clarify this. In 2012, when I was doing my laps in the swimming pool, I designed the trial. But we started enrolling patients in 2018. Yeah, so it took some time to get this trial up and running. As a matter of fact, I remember in 2013, I went to TCT in San Francisco to have a meeting with Marty because I thought, well, I need to get into Edwards because at that time, TAVI was still associated with quite some pacemakers if you were using the core valve system. And obviously in patients with heart failure, you don't want to have a pacemaker issue. So I needed a balloon expandable valve. So it took quite some time to convince Edwards to get some funding for the trial. And that's why it took like 5 years before the trial could start enrolling. And then we took it from there. To answer your question, yes, and this is also an important limitation. Guideline-directed medical therapy in 2018 is different from guideline-directed medical therapy today. We were not using SGLT2 inhibitors. ARNIs were not available at that time. But that same argument also holds for instance, for COAPT or for MITRA FR. So that is inherent to those trials. I think if I would compare TEER treatment for secondary MR in HFrEF and TAVR treatment for moderate aortic stenosis, I think I don't expect SGLT2 inhibitors and ARNIs to affect aortic stenosis. It will affect mitral regurgitation. You know what I'm saying? Yeah.
And one question from the chat from Bunya Budwani related to that. What was the cause of death in the control arm? It was cardiac or non-cardiac?
That's also a good question. It was most were cardiac deaths. Yeah, cardiac deaths.
Thanks very much for the talk. I'll wait for the rest of the trials to be published. Now, I'm glad you actually stressed that this was a heart failure trial. Now, when you're measuring the velocity of jets, certainly your LV function, ejection fraction comes into play. Now, how did you account that this is not all LV function and valve?
Not sure that I understand your question, but you mean that the valve is responsible for the cardiomyopathy?
So when you classify a aortic valve gradient, there will also be a function of how hard your heart can pump the blood out. In the presence of LV dysfunction, how do you account for that?
Yeah. So most patients in the trial had a dobutamine stress echo. Yeah. So that was mandatory to rule out severe aortic stenosis. Does that answer your question? Yeah.
Those patients will automatically more at risk of dying and whether it's purely a follow-up or some of them.
Yeah. So most patients had a history of ischemic heart disease, and the typical, the isolated valvular cardiomyopathies were definitely underrepresented. So we did not have, I think we have a handful of patients where the ejection fraction normalized to above 50% after the valve was deleted. Yeah.
And question from Rob Vincent, our CEO, who apologized for not being here today. Any difference in between groups regarding revascularization?
No. So patients had to be revascularized before they were able to enter the trial. Yeah.
Yeah, fabulous presentation. That was really thought-provoking. I was very interested in the data that you shared from your study on calcification and on the comparison with the dobutamine stress echo. So would you interpret those results as the tests being complementary to each other, as we know that calcification is an independent predictor?
Yeah. So I think that is one of the key learnings, that aortic stenosis should be addressed multiparametrically. It's not just by echo. And this is why also what I answered to the other colleague there, I think it makes sense to refer a patient who is symptomatic and has moderate aortic stenosis to a valve clinic for a holistic evaluation that includes dobutamine stress echo and also includes CT scanning. Yeah.
Can you come to the mic?
So we haven't looked at that. Yeah. And I think that's an interesting one. So we haven't looked at that. Obviously, with CT scanning, you can very well measure the thickness of the leaflet.
Yeah, I've seen abstracts, but I haven't seen any papers. Yeah. But you have the data.
Yeah, so that's definitely something that we could have a look at. It makes total sense. But the focus was on Agassiz score. But we are familiar with the patient phenotype that by echo you see like these dense leaflets, and then by CT you see hardly any calcium. So those are the fibrotic valves. But I agree with you that makes sense. Yeah.
Thank you.
Any further question? And one last, if you have to redo it, what would you change for the TAVI and load?
Honestly, I think the design of the trial makes a lot of sense, and I still believe that it makes a lot of sense to focus on the patients with heart failure and reduced ejection fraction. I think that is the group of patients where we may have most to gain in terms of quality of life improvements. I'm a little bit concerned with progress. To include asymptomatic patients with moderate aortic stenosis and to overemphasize this cardiac damage paradigm. Obviously, the more advanced the damage is, and indeed, if the right heart is also involved, that will be a different phenotype than the patients who have only left-sided damage. But I think what really bothered us was the fact that all of a sudden there is this juggernaut Edwards coming up with a trial and basically undermining the investigators. That was the big. Yeah.
Thank you again. I think we have a meeting with a fellow at 8:30, if I'm correct, in the other room. I think it's a boardroom. Thanks again. I know it was challenging to come here, and a big applaud.
It's an honor. Thank you very much.